Great. Good afternoon and welcome to my fellow commissioners and to members of the public who are attending here in person at the Altman Conference Center, and also to members of the public who are viewing on live stream. Thank you for joining us. Let me start by introducing our agenda for today. We're going to begin today's meeting with an update on notices of material change that we've received since our last board meeting in June, as well as a brief status report on the ongoing situation with Steward Healthcare. We'll then recap some of our earlier discussions on private equity investments in healthcare from presentations and conversations we've had at the board in December and April, before the HPC team shares some potential state policy solutions from the new HPC policy brief on the topic. We'll then review actions that have been taken to implement a health equity lens across all of the HPC work streams and view a new video that will highlight the impact of the HPC's birth equity and support through the inclusion of doula expertise called the Bedside Investment Program. And finally, we'll receive a few updates from our executive leadership team in our executive director's report. To close out the public meeting, we'll then vote on the HPC's fiscal year 2025 operating budget. Commissioners will then vote to enter executive session, and we will not return to a public session following that. So our first order of business is to dispense with the minutes from our last board meeting, which was on June 13th, 2024. Are there any amendments to those minutes from any commissioners? Hearing none, do we have a motion to vote? And second? All in favor of approving the minutes as is, say aye. Aye. And all opposed, say nay. Hearing none, we have approved the minutes. Our next agenda item is moving to market oversight, and I will turn things over to David Seltz to introduce our topic.
Great. Good afternoon, commissioners, members of the public here in person today. I do want to acknowledge it is wonderful to be here in person in the Altman Center. This is, I think, the first time that we've been here together in person with members of the public and the press in quite some time. So it's great to be here in person today. And for those of you joining online, thank you. We know this is a busy day in healthcare in Massachusetts, an important day. We know that the state Senate is planning to debate an important healthcare bill later today, as well as an important day in the Steward bankruptcy process as well. So for those of you who are watching and participating in today's meeting of the HPC, we thank you, and we understand that you might be second screening this meeting and paying attention to all of that other important news as well. We sure are as well. But we do have some important agenda items for you today here at the HPC, and so just to kick it off, I'll turn it over to Kate Mills.
Great, thank you, David. And this next slide, you all know very well, summarizing the material change notices we've received to date. Since 2013, we have now received notice of 170 different provider transactions. Of these, transactions involving the formation of a contracting entity continue to be the most frequent. And on the next slide, you see that at the present time, we continue to have one active cost and market impact review regarding the proposed transaction between Dana-Farber Cancer Institute, Beth Israel Deaconess Medical Center, and the Harvard Medical Faculty physicians at Beth Israel Deaconess Medical Center. As you know, that transaction involves a new clinical affiliation between Dana-Farber and Beth Israel and its physicians, following the termination of that longstanding affiliation between Dana-Farber and Mass General Brigham, as well as the establishment of a new freestanding cancer hospital in Boston for adult oncology patients. On the next slide, you see that we have formally initiated the cost and market impact review, and we continue to work closely with the parties as they provide information in response to our information requests on a rolling basis. That party production to us is not yet complete. So while this is the overall timeline, please know that our clock is temporarily paused as that production continues to be completed to us. We very much appreciate the party's continued collaboration with us to provide that necessary information for our review. And we look forward to discussing our findings in more depth in the coming months. On the next slide, you see since our last board meeting in June, the HPC has elected not to proceed to a cost and market impact review on one transaction, the proposed acquisition of Milford Regional Medical Center by UMass. Under the proposed transaction, UMass would acquire Milford and its affiliates, such as the Milford Regional Physician Group, which operates as a primary care and multi-specialty practice in that service area, and which currently contracts through Mass General Brigham for several large commercial payers. The UMass system, as you all know, includes one academic medical center in Worcester, as well as 3 community hospitals, Health Alliance Clinton, Harrington, which was acquired in 2021, and Marlborough Hospital. I'll note that Milford is a moderately priced community hospital, obviously located in Milford, with a relatively high commercial payer mix. It has recently invested significantly in its renovations and expansions of its facilities, but it has been struggling financially in recent years with significant losses over the past 3 years. In our thorough preliminary review, we found that the parties' service areas are already highly concentrated. The transaction is likely to increase that concentration to some degree, with a concomitant increase to the parties' ability to negotiate higher prices in the future. However, retaining care at Milford in particular, care that would have otherwise gone into Boston or to other higher priced competitors, does have the potential to produce savings. And additionally, recognizing the financial condition of Milford, it's likely that the transaction and the financial support offered by UMass will help preserve access to the services in Milford's region. And in furtherance of that goal, UMass has committed to maintaining all essential services at Milford for a period of 5 years with ongoing reporting. That was actually approved by the Public Health Council as part of the determination of need review yesterday. Weighing all of the various cost of market factors, including that very important commitment around maintenance of services, we did elect not to conduct a cost of market impact review of the transaction. And I'll pause there in case there are any questions. Being none, I will continue on to the next slide. I'm sorry, that was summarizing more on Milford. The next slide. We are also currently reviewing material change notice filings for 3 additional proposed transactions. So 2 of those were under review at our last board meeting, a proposed joint venture between the BMC Health System and Telica Imaging to establish a clinic providing MRI and CT services at up to 3 new clinic sites in Massachusetts, as well as the proposed acquisition of same-day Surgicare of New England by South Coast Health System, which is the nonprofit health system, which includes St. Luke's, Charlton Memorial, and Toby hospitals. And it currently already owns 49% of same-day Surgicare, so this would be acquiring the remainder of it. And finally, on the next slide, since our last meeting, we've also received notice of a new transaction, the proposed acquisition of select assets of BioReference Health, a national clinical laboratory testing company with 2 sites in Massachusetts by the Laboratory Corporation of America. And we will update you on those transactions as findings become available. Finally, that brings us to our update on Steward. So on the next slide, as you know, Stewardship and Optum filed notices of material change with the HPC for the proposed acquisition of Stewardship by Optum last March. That notice was never completed, and Optum has now stated publicly that it no longer intends to proceed with that transaction. However, to date, the parties have not withdrawn those notices. We will, of course, update you when that does happen. And then, as you all know, the sale of both Stewardship Health, the physician network, as well as the 8 Steward hospitals in Massachusetts are of course subject to the ongoing bankruptcy process. And we also wanted to provide you an update there. We are obviously continuing to closely monitor those proceedings. So on the next slide, the key update that we have for you on those proceedings is an update to the timelines, which you see summarized here. So bids for the hospitals in Massachusetts were updated, those deadlines, but they were required to have been submitted on Monday, with an auction taking place today, July 18th. That said, the bids and the auction process are not public. So Steward has only said publicly that it is evaluating the bids at this point. Information about the selected bids may be made publicly available after that auction concludes. And then that same bid and auction process for the Stewardship Health Physician Network has now, the timeline for that has been pushed back an additional week. So that is now scheduled for next week, with bids being due Monday, and an auction being scheduled for a week from today, July 25th. We will of course continue to update you as we learn more, and of course look forward to reviewing any notices of material change filed in connection with these sales. And I will pause there for questions, although acknowledging that relatively little additional information is available publicly at this point.
Are there any bids? Do we know?
We do not know, aside from the fact that Steward has said publicly it is evaluating bids.
I would just add, Patty, I think in the order for the extension of the Stewardship Health dates, there was a mention that they were entertaining multiple bids. But that was what they stated in the public, or in the public filing with the court.
Yes.
Okay, with regards to the physician group, you said that the notice was still open, but that there had been public acknowledgement that it wasn't going forward. Is there an obligation to either move forward or formally withdraw at some point? Is there a time limit for us to consider?
No, there is not a formal time limit to withdraw the notice. In general, if we know that a transaction is not moving forward, we do, after a while, ask parties to withdraw those notices. And so I would assume once the bid deadline passes for stewardship next week, if Optum is indeed not a bidder, that would presumably be something that could lead to them withdrawing the notices. But at this point, nothing has been withdrawn.
Okay, thank you.
You?
Thank you.
Thank you so much.
Appreciate hearing the updates. We're now going to move to the topic of private equity investments in Massachusetts healthcare and the opportunities for state policy. And Director Seltz, did you want to introduce our speaker?
Absolutely. And I'll introduce this topic as well. So commissioners, we're very excited to be able to present before you today and release to the public a new policy brief that we have prepared. This new policy brief really is a synthesis of the presentations and the research that we've presented before you really over the past 8 months or so. So we first brought this topic in a full board meeting to you in December. We brought Dr. Zuri Sung before this commission to really give us a primer on private equity and how it works in healthcare. We then followed up in April at a committee at a committee meeting where we shared some of our novel research here in Massachusetts about the growing role of private equity in Massachusetts. And so what the staff did here was we really just compiled and wrote up our findings and our research to have a policy brief that we could post on our website and make available to policymakers, both here in Massachusetts, but really across the country, because we do think this is really novel work that we've been able to do, and we're quite proud of it. and really adds to the growing body of literature here around healthcare and private equity. You know, we were really motivated to go down this road because we have seen, and as you'll hear, there really has been an acceleration of private equity investment, specifically in healthcare. Private equity investment in all sectors of the U.S. economy obviously has accelerated very much so in the last few decades, but specifically in healthcare, we've seen this continue to grow. And as the academic literature, as you'll hear, there has been this growing body of evidence that there is a clear linkage between private equity investment and ownership in healthcare and impacts on costs, on quality, on patient access to care. There's really important for us to understand where this is happening and in what sectors in healthcare, and specifically, where is this happening in Massachusetts? And it turns out that answering that question is much more difficult than I think we even thought it was going to be when we first endeavored on this research project, because this is not something that is easily tracked. It is not something that is easily transparent to the public. And it's not something easily transparent to even very sophisticated researchers like we have, and the very sophisticated ability for us to avail ourselves of proprietary data sources that we have at the HPC. I think this speaks to a real problem, I guess, which is the opaqueness by which this industry is acting in healthcare, and that we'll return to that when we get to some of what we see as policy opportunities. So today we just really wanted to, as we release this policy brief, just highlight for you again some of those really key big findings that we had presented to you before, just as a reminder, since it has been some months. And then I'll speak a little bit to some of those policy opportunities that we've discussed, open it up for some conversation, but then really have an opportunity to talk about where we may go next with this research, as well as and release this brief and release this report to the public. So this first slide just really describes the outline of what's included within the brief. But I think just to give you the highlights, I'll turn it over to Yua to walk us through some of the key findings.
Good afternoon, commissioners. Okay, great. So I'll start by kind of refreshing our memory a little bit on how private equity works before I dive into our research. So private equity firms, of course, pool investments from large institutional investors and high net worth individuals to make acquisitions. They are different from other forms of healthcare investments in several ways. First, they operate on a short timeline and expect high returns on investments. This means that they often have little regard to the long-term health of the providers they acquire, and might pursue a variety of strategies that can be anti-competitive and destabilizing. And we've talked a lot kind of in terms of the specific strategies they use, such as leverage buyouts and sale leaseback of real estate in previous presentations, so I won't go into the details there. They also benefit from certain tax privileges and sort of operate under the regulatory radar. We know from national research that private equity investments has increased substantially. It's been estimated that the total deal value it's somewhere around $750 billion in the last decade. And on the next slide, I just wanted to highlight some new research that examines various aspects of private equity investments. This is an area of active investigation by researchers all over the country, and a lot of this content on our slide has honestly come out since we last discussed this topic in April. So I wanted to highlight a couple of papers. In terms of the prevalence of private equity investments, I think what we're learning is private equity is really leaving no stone unturned. this latest research that looked at behavioral health practices found that nationwide, 642 mental health clinics and 1,152 substance use clinics were acquired by private equity between 2012 and 2023, representing roughly 6% of all mental health facilities and 7% of addiction treatment facilities in the US. And there is significant geographic variation. In some states, private equity owned practices accounted for almost a quarter of all mental health facilities. In terms of care quality, a big systematic review of private equity's impact on healthcare came out in December last year. One aspect is they looked at a lot of studies that evaluated the private equity's impact on healthcare quality, and they found within the 27 studies, they found 12 that found harmful impacts, 3 that found beneficial impacts, 9 that found mixed impacts, and 3 that found neutral impacts. So I think this is an area researchers are continuing to study, but so far the evidence is, there's more evidence for harm than improvement to care. There's another analysis that has come out that uses Medicare claim that found private equity acquisition of hospitals was associated with 25% increase in hospital-acquired conditions driven by falls and central line infections. This was actually research Dr. Song presented to us back in December. At the time, it was not published, but now it's gone through the peer review process and it's been published. And in terms of access and market impact, I remember in our April meeting, we discussed exit strategies of private equity, and now we have research that has looked at this very question, although it's in the kind of physician practice market. Researchers looked at 800 private equity exits from dermatology, ophthalmology, and gastroenterology practices. These are specialties that have high penetration from private equity. So researchers looked at exits from these specialties from 2016 to 2020, and they found that over half underwent an exit within 3 years of the initial investment. And in almost all cases, private equity firms exited their investments through a secondary buyout, meaning they sold it to another private equity firm with larger investment funds. Another analysis tracking bankruptcies of healthcare companies found that 17 of the 80 healthcare companies that filed for bankruptcies were private equity owned in 2023. So research is coming out all the time, but I just wanted to provide a highlight on some of the new work that has come out that really furthers our understanding of private equity's impact on healthcare. On the next slide, this is a summary of our research. In Massachusetts, our work found.
Commissioner.
Question, sorry.
Thank you, Yue. I'm sorry to interrupt, but
No.
but back at the specialty practices that you were describing, is there any sense yet as to whether there are shared characteristics among those practices that make them more appealing to private equity? What do we know about what attracts private equity to particular types of practices or particular types of healthcare?
Yeah, I think it depends on the sector. I think one common characteristic we found based on our research is that private equity is often interested in sectors of the healthcare system that's fragmented, so there are opportunities to consolidate. This is, I think, evident in their investments in the physical therapy providers. The dental market is very fragmented. For these specialties, I think one characteristic is that, for example, for dermatology, there are opportunities for procedures that are not necessarily covered by insurance. So patients, they might have a lot of patients for self-pay and sort of elective procedures. Some of them might be cosmetic, for example. For gastroenterology and ophthalmology, my understanding is that there are also a lot of opportunities for sort of procedures that these practices can offer. So private equity might see that as an opportunity. And then for kind of other sectors of the healthcare system, for example, hospital and nursing homes, private equity might have different motivations, or real estate is an example of why private equity might be interested in hospitals and nursing homes, because those type of facilities often own the real estate that the buildings are on. So I think it kind of depends on the sector.
I think that's critical information to keep track of, because, you know, folks go into a partnership not realizing until they've signed the contracts that they're in trouble. And to the extent that folks can become knowledgeable as to what makes them susceptible, they can become better aware of how to protect themselves in terms of partnerships, contracts, and other what they think might be growth opportunities. So, you know, whatever we can do to continue to encourage that component of the research. What's the vulnerability factor? I think that's equally important. So I congratulate you for doing that, and would encourage that continue to be a big focus as we get more data.
Thank you.
Thank you.
One interesting point you raised about a sector being able to get out within 3 years. That's very successful from their perspective. But there is a piece of good news on this too, because when private equity comes in and acquires a firm, let's call it, right? The objective is to get out within 3, 5, 7 years, right? But in order to do that, they have to have the firm look attractive as well. So that's something else that becomes a positive. And how do we ensure that that happens? Apparently in these sectors, they've been able to sell in 3 years. So it would be interesting would be to look at the financials. That has to be positive, right? And then what about the quality of care in those particular sectors that have been able to sell in 3 years? That would be a good analysis to do.
I'm going to keep going on our research. So you've seen this slide before. This is our research on private equity investments in Massachusetts. What we found is that private equity investments in Massachusetts have accelerated from 2013 to 2023, both in terms of the number of transactions as well as its share of all transactions. So private equity is in the blue here. And we found that of the 199 healthcare provider transactions in our analysis, 51% involved private equity firms. So that's 101 transactions altogether. Within these, 85 were private equity acquisitions, 4 were exits, and 12 were acquisitions and exits, meaning a PE firm selling to another PE firm. And on the next slide, you can see that private equity investments in Massachusetts have been especially active among behavioral health providers, home health providers, dental providers, and certain specialty providers such as physical therapy providers. Next, I wanted to give an update on recent federal actions. The federal government has signaled strong interest in increased oversight and enforcement regarding private equity. Several pieces of federal legislation have been proposed to increase transparency and limit private equity investments in healthcare. I listed a couple examples here. These kind of, they tackle various aspects of private equity. In terms of federal agency actions, the Federal Trade Commission and the Department of Justice finalized revised merger guidelines a few months ago that address certain private equity behaviors, such as allowing the consideration of the cumulative effect of small serial acquisitions in their antitrust review. And one notable lawsuit was also filed in September 2023. The Federal Trade Commission filed suit against U.S. Anesthesiology Partners and its private equity owner, Welsh Carson, alleging this multi-year scheme to consolidate and monopolize the anesthesia market in Texas. The latest update on this lawsuit is that a federal judge has dismissed the private equity owner from the case, but it's allowing the suit against the provider group to to move forward. So we're keeping a close eye on this particular lawsuit. On the nursing home front, the CMS recently issued a final rule that defined private equity companies and real estate investment trusts, sort of paving the way for identifying nursing home ownership by these entities. The nursing home ownership data from CMS is not new, but this is one way CMS is improving the data collection that'll make it easier for government researchers and the public to know when these entities are owned by private equity and other entities such as real estate investment trusts. And the Department of Health and Human Services has also proposed minimum staffing standards in nursing home to enhance the safety and quality in nursing homes. So I'll stop there unless anybody has questions before I turn it back to David.
I just want to illustrate one of the complications here, and it comes to something Ron was talking about, which is in some ways, private equity is too broad a description. Because if we think about things like take Iora Health, which was born in Massachusetts, that was technically private equity, but it was centered around creating a better practice of primary care, and it's since been sold at huge valuations and stuff like that. But they weren't looking for a quick return. They were really looking to provide better care. And they did that. That is, you know, the returns on the savings were sort of big and stuff like that. And then there's the version which is, no, we want to buy the local dermatologists, get them all together, raise the prices, and collect a lot of money on dermatology, and then be out in a couple of years. And both of those may be private equity, but they're very different sorts of activities. And so part of what's difficult here is that the same label can apply to things that are valuable, trying a new primary care practice with the idea of trying to do better. Even if it doesn't succeed, it's still worth trying. And things that are clearly just designed to milk the system out of money. Just say, hey, where can I make a quick dollar by raising prices or by giving people some services that they may not even need. And I know you had that up front, and I think it's just worth stressing that we don't want to prevent a new primary care model or even prevent the better model of dermatology. But it's terrible that you can come in and buy a dermatology practice and 7 others and then raise prices because you're the only dermatologist in town. So figuring out how to differentiate between those two is really important.
Something else that comes into play is what business is the private equity firm in when they, let's say they acquire a skilled nursing facility. Are they in the skilled nursing business? Or are they in the real estate business?
Mm-hmm.
You really have to take an additional step and look at all of that. Then the question becomes, how do you regulate it? Not easy.
And just on that point, the CMS version of the nursing home regulations, which is what you were mentioning, that's really a sort of neutral policy. That's just designed to say, if you own a nursing home, here's how it has to operate. In some ways, that may be better than trying to say, if you're a private equity owned nursing home, here's how you have to operate, because some of those may be experimenting, you know, some of those may be better and some of those may be worse. So it's kind of laying out a minimum standard.
If I could just add another dimension to this discussion. It seems to me that we're also talking about access to capital. Because if I think back to a lot of the material change notices, they're notices where hospitals have sold assets, labs, imaging, other services to basically get capital to pay down bonds and other needs. And that's on the nonprofit side. So it sort of begs the question, where is their capital in the healthcare marketplace and how is it used? And something to think about as a sort of another set of research, particularly because I think where a lot of community hospitals are struggling here, And they're, they've sold off a lot of assets in order to raise capital. And what happens next?
Yeah, so just to reflect on what we're hearing, I think in terms of future resource or research, looking at what happens and the result across an industry, and then seeing how the investment influences that. So for example, you gave a statistic about bankruptcy, understanding how bankruptcy with private equity investors differs from bankruptcy without private equity investors, and then what seems to correlate the type of investor, whether it's because they're not in that industry or whether they didn't have an original mission to improve it, or what explains it. I think we're hearing from the commissioners would be some thoughts for future examination and interest.
Yeah, that's really helpful and some great thoughts. And Professor Cutler, I appreciate you making some of those distinctions. When I think of Iora Health, I think of that more in the venture capital space, and that I think that a little bit differently than kind of what we're trying to think about with this private equity. But it is a little squishy, right? And so I think we do need to be thoughtful in how we're making some of these distinctions. And I think that's a great segue to what we have identified in this policy brief as some of our initial state policy opportunities. So this slide is really reflective of some of the conversations that we've been having here among the commission, and also some of our longstanding policy recommendations that have been in our cost trends reports for some time. This first slide really is around creating an even playing field, a commonly accepted set of rules, and having transparency that applies to everyone. So first is really around amending our material change notice processes so that we're receiving notice of these types of transactions when there is a private equity investment or an acquisition of a healthcare provider in Massachusetts, just as we would if it was another healthcare provider acquiring another healthcare provider. We get that when it's a provider to provider. We don't get that when it's a private equity investor with no other healthcare operations in Massachusetts acquiring a provider in Massachusetts. We see as a loophole and something that is a gap in our market oversight. Yep.
As you go through this page, particularly here, can you indicate what we could do on our own and what we would require legislation? What would require legislation for us to be able to do it?
Well, many of these topics are currently under deliberation by the legislature.
Yeah.
And under current consideration. And I think we're very optimistic that many of these provisions will be included in a final piece of legislation in the next 2 weeks.
But this one requires legislation.
These changes, require changes to our current rules.
Not quite sure I totally understood. Okay.
Yeah, so let's keep that in mind as we hear about the policy opportunities and think through really the response to that question.
So here, really, what are the types of transactions that are trigger notice and review? And so we've laid out a few here that we think would require that same notice and review, just as we notice and review other types of notable provider transactions. The second part here really is around our registration of provider organizations. which is, our ability to collect information, financial information, and organizational information around a wide range of provider organizations in Massachusetts. Currently, the law has a threshold that is around $25 million in commercial revenue. We think that could be changed to include self-pay Medicare and Medicaid. That would allow us to potentially bring in a broader range of provider types that, as we saw in our research, that may be targets of private equity investment. And so that would be able for us to be able to get that same type of organizational, financial, and structural information on a provider organizations that may very well be the same organizations that are being targeted by private equity.
Does the threshold on the material change notice also need to change?
That we can, no, that we have some flexibility on in terms of what the dollar amount set there is. And finally, we mentioned in the brief here, an opportunity for the state to consider a process for imposing conditions on these transactions. And we note that there is an opportunity to think through, what would conditions look like if concerns were raised in a review of a transaction, and what those conditions could look like in a transaction like this. On the next slide, this next recommendation really is a reflection of some of our longstanding HPC recommendations around some of the mechanisms that we all see in the marketplace for pricing power, and that private equity and others have taken advantage of in our healthcare system, ability to extract higher pricing that really is not related to value. This is not generally specific to private equity, but private equity and others see these opportunities where you can extract higher pricing. We've identified, for example, facility fees, some out-of-network billing situations. We have long recommended policies to close those types of opportunities for higher pricing that doesn't provide value. We see that as another way to close some of these loopholes. And then finally, we mentioned a few other opportunities. Health planning, revitalizing health planning in Massachusetts as an opportunity to make sure that our supply of services more closely aligns with need. We mentioned an opportunity to reduce administrative complexity and the administrative burden on physicians and on providers. That is often cited as one of the reasons that providers are looking to sometimes join larger systems, is because they are just so overburdened with the administrative burden that they have. So whatever we can do to reduce that, I think is all to the good. And then we mentioned here other opportunities. I think these are kind of in the opportunities for further research that policymakers could look to. So these were just our list of kind of policy opportunities, some of which very much align with our recommendations, some of which I think are areas for further consideration and research by policymakers. Many of these are, as I said, under active consideration by the legislature, and I would say we are, really enthusiastic about both branches' commitment to move this forward, move some of these ideas forward. This is really important that we get a bill passed, because these are really important gaps that we have in our current oversight, and with the moving some of these policies forward will go a long way to ensuring that we're really stepping up our oversight to protect patients, protect healthcare workers, protect the stability of our healthcare systems. And so I hope to be able to be back before you in the fall with a report that says Massachusetts has really taken this next step to address some of these issues. But I'm also happy to take questions and comments.
Yeah, I I had a quick question.
Yeah.
You had mentioned oversight of roll-up acquisitions in your federal suggestions. And are we, I mean, I'm noticing when we do the material change notices, the same names keep coming up over and over. And so are we tracking what the cumulative impact is of that? And to Marty's point, the community hospitals selling off different parts of their practices to get the capital needed. So it feels like it's a very local issue as well as a national issue.
Yeah, I can speak to that in the affirmative. We are kind of keeping track of longitudinally some of these serial transactions. I think I know which one you're thinking of, and there certainly has been as we've seen certain hospitals and health systems really selling off certain lines of service lines, and we want to be able to track how much that market is changing. So the short answer is yes. Right.
It's a little bit different in the federal context because there's a hard dollar cap that says if the deal value exceeds something like 115 million, you're required to file a submission with the FTC. If you're under that dollar amount, you do not need to file. So it's a little bit different from the federal context.
Just want to play this out a little bit because in the economics community, when people talk about this, they don't talk. I mean, so this is like clearly like a very expansive proposal. The alternative of what if you don't do something like this is typically things like, fine, let's just go set a maximum rate for that the dermatologist can charge. Like if you're going to roll up all the dermatologists and then try and raise prices 80%, no, we'll just say the maximum price you can charge is 10% or 30% above Medicare, whatever it is, and you just can't do anymore. So within the economics community, it's not like, is this a good idea or is this not a good idea? The issue is like, is this the right idea or is the next best alternative a better idea? And the next best alternative is really very heavy-handed here. So one can have different views about whether the HPC should be given the authority to set maximum dermatology rates or not. But I think something short of that, which is like, you got to be looking out for, that sort of thing is clearly really needed here because you can't expect that like a monopolist is going to own dermatology in the Worcester area and then decide to price really low so that people can go access all the services. That's just not going to happen.
Thank you.
I wanted to follow up on Marty's point about access to capital and something that we can consider as part of this conversation, which is many nonprofit operators, as they assess future next steps and how to meet needs in their communities, are not necessarily, or first and foremost, thinking about let's go straight to some of these more complex financial approaches to get access to that capital. But I think us all understanding that the reality of healthcare operations is that you've got your day-to-day things and your year-to-year things, and then you've got your big ticket things, just like any other household. And when you do need to make those capital investments, both in the US and here in the state, we've found, I think, creative public-minded ways to think about how we finance capital improvements for assets that are essentially public goods, like our community health centers. And maybe some of those models for how our nonprofit, community-oriented, high public payer mix safety net providers are able to access capital in a non-sort of predatory or usurious way can be part of that conversation.
Well, thank you. And the brief is available on our website. Go check it out. So with that, I am excited to move us on to our next agenda item and to, thank you, Yua, to call HPC's Chief of Staff, Hannah Klumak, to provide to the board an update on the commission's activities on our health equity lens in action.
Great, and welcome. We look forward to your comments, Hannah. And I'd like to ask our committee chair, Commissioner Barbara Blakeney, who chairs the Care Delivery Transformation Committee, to introduce our topic.
Thank you so much, Chair DeVoe. And it's a real privilege to tee this up this afternoon. And as you turn our attention to the presentation of the Commission's application of health equity lenses across all of the work that the Commission does. Now, the definition of health equity is the opportunity for everyone to obtain their full health potential without disadvantage due to social position or circumstance. We know that the COVID pandemic both illustrated and exacerbated healthcare inequalities and disparities. However, we also know that those disparities have long existed. While Massachusetts is a recognized leader in healthcare, in innovation and access, the gaps in access to high quality and affordable care are still staggering, especially for people of color. A report by the Blue Cross Blue Shield Foundation released last summer found that the cost of health inequalities experienced by communities of color in Massachusetts amounted to 5.9 billion, that's billion with a B, each year, an outrageous amount. There is both social and economic, and I would argue moral imperative to reduce this burden of inequalities in Massachusetts. Throughout its work, the Health Policy Commission can provide expertise across a range of policy levers to help achieve this goal, partnering and collaborating with other policymakers to move the needle toward a more equitable system of care for our residents. So with that, I am extremely pleased to turn the rest of this agenda over to the Commission's Chief of Staff, Hannah Kuhlbeck, who will share some of the updates of the Health Policy Commission's equity streams. And I appreciate very much the opportunity to present this topic. Thank you.
Thank you, Commissioner Blakeney. How's that? Better? Okay, great. I feel like I personally speak very loud, so I like to keep microphones farther away, but I'll try to moderate my tone. Okay. So as Commissioner Blakeney mentioned, persistent health equities in the Commonwealth have been well documented and lead to both higher spending and an imbalanced distribution of resources. As you'll see on this slide, the HPC's mission statement clearly identifies equity for all residents of the Commonwealth as one of our core principles, as does our founding statute, Chapter 224. To advance this goal, we embed health equity concepts into all aspects of our work and strive to create a culture of equity and inclusion within our agency. This work is ongoing, and we are committed to holding ourselves and the work accountable, part of which is providing this annual update to all of our commissioners and to the public at large during our board meetings. So since last summer's annual update on the HPC's health equity initiatives, we've continued to refine how we apply our equity lens to both our public work and our internal processes. At the core of this is our equity in everything approach to integrating health equity principles into all operations and work streams. We have intentionally designed our program, policy, and research activities around targeting inequities, as well as collaboration with other state agencies and organizations towards common health equity goals to ensure a broader impact. Our teams continually track and review these projects to ensure that they are being approached in an evaluative way. And we also carefully follow the latest advances in data and methodology to enhance our agency's work products. This slide is very familiar. So these are our 4 core strategies, and the HPC takes action to advance health equity across each strategy. And I'll provide a couple of examples of those actions on the next slides. So starting with research and report. There's a lot of text here, but I'll just highlight some of the work that we've done this year to illuminate health equities and disparities through our research. Integral to this work is a commitment to utilizing the best available data on race and ethnicity in our research and data analyses. While this can be challenging, given that the all-payer claims database does not include race and ethnicity data, we recently were able to tie hospital discharge data with the APCD to examine disparities in severe maternal morbidity. This was a huge advancement in our capacity to identify health inequities, and that research was presented at a committee meeting earlier this spring and is available on our website. go into market oversight. During reviews of proposed market changes, which our team has had a lot of, as Kate mentioned earlier, we factor patient characteristics into the potential impacts of each transaction and also review the entity's plans for improving equitable access to care in order to mitigate harmful effects. For example, through programs to improve cultural competence or transportation supports. These are a few of the different ways that we convene conversations with our stakeholders and partners around equity and engage broad perspectives. I want to highlight specifically the annual healthcare cost trends hearing as an opportunity where we've utilized to focus attention on issues related to health equity and disparities. For the last several years, health equity has been an explicit theme in the event, featuring in the conversations and questions posed to witnesses during the annual hearing. Last year's hearing in particular kicked off with our opening panel featuring community voices discussing the most pressing concerns of healthcare affordability and equity. Those 4 panelists shared their experiences and the experiences of the communities for which they advocate for in combating equity and affordability challenges, which really helped to inform and focus the rest of the day's conversations and reflections. We've found such value in all of these discussions during past meetings and events. We look forward to further opportunities to incorporate a diversity of experiences with the healthcare system into our upcoming events and meetings. Our last lever is partner. We know that this work does not and cannot exist in a vacuum. And in order to make a more effective impact, we're proud to align, collaborate with, and support other state agencies, organizations, and partners in the healthcare system. One area in which we've really advanced work through partnership is maternal health equity, which is one of 2 core focuses for the Healey-Driscoll administration's Advancing Health Equity in Massachusetts initiative. We're so grateful for the leadership and collaboration led by the secretary and her team at EHS, and so pleased to be able to contribute to this critical initiative, lending experience with data analysis and the learnings from our past investment programs. The HPC now has 2 investment programs that are focused on improving outcomes for birthing people. The latest investment opportunity in the maternal health space is our Heart BP program, which is a $1.5 million program focused on providing remote blood pressure monitoring services to address existing inequities in severe maternal morbidity that are driven by hypertensive disorders in pregnancy. Hospitals that often serve patients experiencing these inequities, such as rural hospitals and hospitals with large Black and Hispanic birthing populations, will be strongly considered during review and selection of awards. That opportunity is open currently and is accepting applications until September 6th. Have to put the plug in there. And we're very excited to be able to report back to the board when we have further updates on applicants. That program and our other maternal health investment program, the Beside program, align well with the Advancing Health Equity in Massachusetts initiative. So our Beside program funds 2 initiatives that provide racially concordant doula services to Black birthing people. More than 70 Beside babies have been born since the start of that program, which leads me to be able to introduce a brand new video highlighting one of our Beside awardees, Bay State Medical Center. This video was planned and produced by members of our Healthcare Transformation and Innovation team to show the impact the program has had on the participants and the awardee hospital. I am so excited to be able to share it with everybody today. So if we're ready, we can play the video.
When I got inaugurated in January of 2019, the first week on the job, March of Dimes came and gave a presentation to women legislators. I learned that Black women were dying 3 to 5 times the rate of white women before, during, and after birth. I was shocked. As I walked out of the room, I was in tears. And that has led me on a journey to really understand not only the state of Black maternal health here in the Commonwealth of Massachusetts, but around the country.
We know that there are huge disparities in outcomes for Black birthers in this country, and those disparities have persisted over decades, despite many advances in other areas.
I've had patients or their family members come into prenatal appointments and say, I've been hearing about these stories in the press. I'm worried I might die. What will you do to keep me safe? And that's the reason for the focus of the Beside program. The program is an investment by the HPC that matches doulas with Black birthing people.
A doula is a trained, educated birth supporter. Doulas often form a connection with patients before their actual birth and do a lot of support, advocacy, and education. They help bridge a divide that often exists between patients and healthcare system that they're unfamiliar with and maybe are mistrustful of.
The reason that this is happening is due to medical racism. The B-Side program centers racial equity, making sure that clinics, providers, doulas, and the birthing people have a mutual respect and understanding for each other. What we found is that there's lots of challenges, implicit and explicit biases, centering on racial equity and having culturally competent doulas who speak the language, who understand the lives of these birthing people is critically important.
B-Side started with 30 women of color, and we followed them through pregnancy, labor, birth, and postpartum. A lot of times for women of color, we feel like we're never being heard or listened to. So it's important for us to support our client to be able to speak up if there's something wrong, or to be able to speak up if they feel like they didn't understand what their healthcare provider said. So just that clarity between both is important. We support the mom to be able to empower herself to speak up.
When I went to my appointment, the doctor asked me if I wanted to be a part of the doula program. I honestly didn't have that much knowledge before, but I was interested and I was ready to learn about them.
DeAndre was lovely to work with. She was just amazing, strong mom. I'm glad she opened herself up to having a doula. Pregnancy can be a roller coaster, and labor can be the same way.
I was 23 weeks and one day. I started having like really bad pain, and I went to the doctor and I never left. I went to the hospital and I never went home. I had placental eruption. There was a possibility that my children were gonna be born at 23 weeks, and there was a possibility that they were not gonna survive. So all that time being in the hospital was just, are my babies gonna make it? Are my babies gonna make it? And nobody knew.
There were some unknown things happening in her pregnancy, so it was nice to be there to just listen to her and support her. I think that really helped her to be able to relax a little bit or lessen her stress and anxiety.
Having a doula helped. She called me, she texted me, she visited me. It was easier talking to her than it was talking to some of my family because she had been through situations like that. And I didn't know what to expect. Every week was a milestone. I went in for a scheduled C-section at 35 weeks, and Laconia came and she stayed by my side. And when the babies went to the NICU, she stayed with me while my partner went up to the NICU with our kids. She made me feel so comfortable and so safe during that time, and I really appreciated it.
Every hospital needs a doula program. Any program that seeks to improve the experience and reduce disparities in outcome for Black women is a good investment and one of our highest priorities in terms of making sure that everyone is getting the best care they possibly can.
Black and brown birthing people are the ones who are suffering the most, and we should center them. We're focusing on improving outcomes for everyone through impacting those that are most impacted.
I wanted a doula in general, but her being of the same racial background was a plus. We're not heard as often, so her being there for that emotional support and to make sure that I'm receiving the proper care that I need.
I can't even think about being pregnant right now and everything going on in the news, social media, talking about Black women are dying at a high rate, our infants are dying at a high rate. That's scary. What I tell my clients is we're gonna be supported and grow a supportive team during that time so they're not feeling that and carrying that as they're going into the hospital to give birth.
We want babies to survive, want birthing people to survive. We also want to make sure that we have the Beside program actually in every hospital in the Commonwealth. And so we have a lot more work to do, and I don't want to keep our feet off the gas. Massachusetts has always been a leader. The way that Massachusetts goes, so goes the nation. through innovation, we can really address the maternal inequity crisis.
Thank you so much. I really want to take a moment and acknowledge our HPC Beside team, who has managed these two programs over the last couple of years, and particularly shout out Jasmine Bland, who has managed and championed the Beside program since the earliest days of its design phase. And I also want to thank Senator Liz Miranda for her tireless work advocating for Black maternal health equity, for supporting this program since its earliest days, and for joining us to participate in the video. It was great to have her included and have her voice featured in that video. Wonderful. Okay, so I would love to hear any thoughts or comments from commissioners. So before I pause for that opportunity, just want to quickly highlight that over the next year, we plan to release several publications that will provide new research and data on equity trends. There are a few items listed here, and these are just a few of the things on our agenda. So I will stop there in case there are any thoughts or comments.
Terrific work, terrific work. Makes my day, not my weekend month, but any other comments or thoughts, questions, please?
I think one of the things that impressed me the most about the work that the commission has done in the last 2 years to bring equity and inclusion deeply into the work, you know, equity in everything is a powerful kind of claim. And the way you do it is to systematically build it into the processes. And I think what I've seen here is that that's exactly what the staff has done in a very systematic way. They have looked at what equity and inequality both look like. They've looked at inclusion. They've looked at all of the components of a JEDI program and have found ways to systematically put it into the processes. And that, I think, is the power of what this program has done. And I think it speaks very highly to the probability that the work that the commission does going forward will be strengthened because it is systematically and institutionally included in the process. So I want to congratulate the staff for the work that you've done to very insightfully see the importance of that and to make it happen. So congratulations, everybody. Very well done.
Thank you.
Thank you. Wonderful. So as part of our continued, oh, is there another thought?
Well, I was, is my voice on there? Just wanted to also acknowledge and thank so much the Health Policy Commission from the start in terms of our collective statewide. We're all part of one government family efforts around advancing health equity. You know, David and others were there at the beginning last summer as part of, you know, co-design and co-development and really opening up some of, you know, the inside, you know, deliberations around, you know, what are some of the top areas where the data are leading us and showing us that we have disparities, and let's spend less time, you know, sort of agonizing over, you know, 1, 2, 3, or 4 and kind of honing in on some big areas and let's go. And so that coalescing around the perinatal health and also around sort of the social drivers, the root causes of a lot of these disparities, that was that didn't take a long time to get together. I think we really are very grateful to the staff for their partnership, you know, at every level in this work.
Thank you.
Yeah. And I think, you know, we mentioned that earlier, but all of this work is the most effective and most meaningful when we work in partnership. So very grateful to the administration, very grateful to EHS and then the rest of our partners. So we will continue to keep the board updated on all of this work. And I would have to plug that all of the information is available on our website. So if you want to read in more depth, please find it there. Thank you so much.
You.
Thank you.
Thank you. So we will now turn to our executive director's report and turn it over to David and Colleen.
Need to be elevated. All right. Oh, it's so lovely to see you all in person today and to be in person together this beautiful summer day. I will begin with the executive director's report. Thank you, Director Seltz, with our first slide with a very brief high-level legislative update. The 193rd General Court will conclude formal legislative sessions on July 31st, after which it is very unlikely major legislation will get passed until the legislature reconvenes in January 2025. The House and Senate have been pretty active this session when it comes to healthcare and health policy in that space. We are closely monitoring on this slide a few healthcare related bills that are still pending. Including that includes some type of role for the Health Policy Commission. Most notably, the two market oversight bills that passed the House in May and one that is expected to pass the Senate today. We have been working with staff and members on both of those very important bills. The content of which, needless to say, if passed into law, could drastically change the content of the HPC's work and the future of the Health Policy Commission. So details matter, but the good news is both bills have similar themes and similar goals, and both are aligned in supporting many of the Health Policy Commission's policy recommendations that we've put forward over many, many years. So that's the good news. And I will say we are hopeful that this does get done. And grateful to everyone who has worked so hard on these bills. So next steps, details to be hashed out in the conference committee process with members of the House and Senate over the next couple of weeks, and then it'll go to the governor for her consideration. Also on the docket is the state budget. The legislature is also working to finalize the FY25 state budget. Director Seltz is going to talk about the HPC's administrative budget moving forward and how that affects us, but we're going to continue to work on all of this. Any further developments as the session winds down, we'll be in touch with the board. 2 weeks left, but we'll have an update very, very soon as we wait with bated breath. Yeah, I have no breaking news, but hopefully soon. All right, on the next slide, this is my favorite part of summer at the Health Policy Commission, our annual summer fellowship program. This program has two goals. One, obviously helping support the work of the Health Policy Commission, the Commonwealth's healthcare cost containment and affordability goals, but also providing hands-on educational opportunities to the next generation of health policy leaders. So each year we have incredibly talented students. It's a 10-week program here at the HPC, and everyone does a standalone policy project, research project within one of the HPC's departments. We're so privileged to have the energy and the perspective of these students every year. This year was an incredibly competitive applicant pool. We had hundreds and hundreds of applications. Thank you to all who applied and showed interest in this program. But we picked the best of the best. So we have 7 students from universities and programs across the country, future economists, lawyers, medical professionals, public health professionals here, all in graduate or doctoral programs. So the fellows are halfway through their summer programming here, but they're all in the room with us today. So if you want to just give a little wave, Annie, Annalisa, Emily, Casey, Elizabeth, Haley, and Zakia. Thank you so much. I will make you stand up. And then on the next slide, the Academy Health Annual Research Meeting. This is the nation's largest forum for healthcare research and health policy. 2,500 attendees every year from all over the world. It was in Baltimore this year over 4 days, and 5 of our research and cost trend staff attended. There were 1,700 posters, dozens of podium research presentations. This year, HPC's own Alicia Duran did her presentation on severe maternal morbidity in Massachusetts, which was a huge smash success. And we had 6 posters. All of the posters are in the hallway here of the HPC as you come into the Altman Conference Center, and they're obviously all posted on our website. One of the posters was selected as a student poster walkthrough. That's the one shown in the picture with all the students. You can tell them by their backpacks at the poster there, which is a really, really big deal. It's about shifts in sites of flu vaccine. So just incredible work. And kudos to our research team, represent Massachusetts and represent the HPC so well every single year at the ARM. So thank you. All right, the next slide is actual breaking news. I'm really excited about this. So speaking of our website, I have to say this is a pretty big deal. We have a new website. Our new home on the internet is masshpc.gov. This has been a work in progress, a labor of love and a labor of pain for some time now, but we're so happy to finally share it with you all and all of our stakeholders and all of our audience. Obviously, please visit and peruse for yourselves. Right on the main page are all of our research publications on all the hot health policy topics, the most pressing things facing the HPC. So that's the best part of this. But we built it very intentionally with great new features and functionality. So I just want to shout out and highlight a few of those. First and foremost, we have great navigational tools now. So there's menus, there's filters, there's search options, help you find what you need quickly and easily. We also have embedded videos, which is a big deal. You can watch our special features like today's Beside video, HPC shorts, even our public meetings right on our website. So you don't have to go to the YouTube channel to find everything. We've also got a priority section for our Office of Patient Protection. So it's easier to find information if you want to file for an if you want to request an open enrollment waiver, I can't say that word, or an external review. So much easier for OPP folks to find that. So bookmark it, turn to it. Our new resource here for the website. I want to thank especially Hannah Klumak, our Chief of Staff, Becky Wilmer, Aisha Anderson, for building this new website for us. All of our staff who have put so much time and effort into it. It takes a village to build a new website after 12 years of information that we've put out into the world. I also want to shout out our General Counsel, Lois Johnson. Not easy to keep a .gov URL, but if you want to send in your top negotiator to get that done, you send it to Lois Johnson. So thank you so much, Lois, for getting that done for us so we can be a .gov till the end of time. That will be our legacy here. All right, I got one more slide and then you can turn back over to the business of the HPC. So publications, I won't go through all the recently released work that we have on the website, but just to highlight a few of upcoming works. We've got data points coming out on GLP-1, blockbuster GLP-1 weight loss drugs in Massachusetts. We've already talked about this with you all. Serious implications for affordability and access in Massachusetts. So we're going to share all the data we put forward in a new interactive format. We've got a new chart pack coming out, I'll highlight as well, on the primary care workforce. This continues our previous research in the workforce area, but taking an important look at this particular landscape and how it will affect patient access across the Commonwealth. And last but not least, we have our evaluation report coming out on our C4CEN investment program, our substance exposed newborns investment program. Really proud to share that, just talking all about the impact of that program. Supported initiatives for improving the quality of care for caregivers with substance use disorder and their infants as well. So we dispersed $1.5 million to 5 awardee hospitals and had more than 200 infants in that program. So please check that out to look at the impact of that absolutely incredible program. I think that's it, David, for the executive director's report.
Colleen, where can people find all of these wonderful publications?
masshpc.gov is our new website. Yes, everything's up. I know there's only one place now. So thank you so much. That's it.
Thank you. And I second your comment about our summer fellows. I had the opportunity to meet with them today, and they are our future. There's a lot of good reason for hope. Good luck to you as our future. So we'll now turn to our last item for the public agenda, which is a discussion and vote on our 2025 fiscal year operating budget.
Great. Thank you, Chair DeVoe. I'll give an overview of our fiscal year 2025 budget. But I just first want to note that we had an opportunity to meet with the committee of the Administration and Finance Committee of the HPC board earlier this week on Monday for an hour to go through last year's budget performance as well as this upcoming budget request in some depth. So I'll go through it at a high level, the plan for the year, but also would invite members of the committee to offer their perspectives as well. So as a reminder, the HPC's budget is set every year as part of the annual state budget process through a line item. Different than many other line items in the state budget, though, it is an assessed account, which means that the amount that is set in that line item each year, the Health Policy Commission then assesses that amount to certain healthcare entities, in this case, ambulatory surgery centers, acute care hospitals, and health insurance companies. We assess those entities for the full amount of the line item. Those monies are then deposited into the state's general fund, essentially making the line item net neutral for the state budget. For fiscal year 24, the HPC's total budget available for expenditures was 11.8 million. And then for fiscal year 2025, which began on July 1st, the HPC requested from the administration and from the legislature to fund this account at $12 million. This represented about a 2% increase from that total available in last fiscal year. And really, this number represents an annualized cost of our maintenance operations, which really just means what is the annualized cost of continued operations for the HPC. And this was really a request from the legislature and the administration in terms of how to craft this budget request. So on the next slide, just to give you a sense of how this budget process has gone through this year. As Colleen mentioned earlier, the state budget has not been yet voted on and is not yet complete. So why am I here proposing our budget? Well, I do have some confidence that I think we have some confidence that we know what our number is going to be. As you can see here, the governor, the House of Representatives, and the Senate all funded the Health Policy Commission at the exact same amount, that $12 million as we requested. And so that is the budget proposal that I'm about to present before you today. I will say if there is a different amount included in the final budget, I would obviously come back to the board and would adjust the budget accordingly. But typically when you see the same number in all three branches, there's a high likelihood that that will be the number in the final budget. So working off of that $12 million on the next slide, want to just say a few thoughts about what that assumes and what that does not assume. So as I mentioned, this really is just kind of an annualized figure for our current kind of staff and obligations. We do know that we have some upcoming obligations for fiscal year 2025 that go beyond kind of our standard responsibilities. That includes the final evaluation of the MGB PIP. And we do know that we're going to be working on the 5-year retrospective of the Beth Israel Leahy merger. So those were contemplated as part of the funding request. Each year, though, with these funding requests, though, there's a lot of unknowns. There are so significant unknowns about the number of market transactions that will come before the HPC. There are significant unknowns about potential drugs for referral from Mass Health for a value assessment. And each year it's very difficult for us to be able to predict exactly how many and what timing and in what type and scale those reviews may be. And so each year I always kind of have that caveat in place with the budget request. This year, there's an even bigger caveat because when we first developed that $12 million figure, we did not anticipate what we now know and anticipate to be significant amount of market changes that will be likely this year. We don't know that the HPC is likely to have an important oversight role in many of these changes, in addition to our potential role in this. We also have been providing important in-kind support to the administration through data analysis and consulting support. We would expect to continue to do that, of course. So this is a big unknown in terms of exactly how much resources will need to go into this. That was not anticipated kind of when we were first putting this budget together. Additionally, I would note this budget request does not include any additional resources or staff that would be needed if legislation were to pass.
Right, I just want to note that mandates from the legislature without funding attached are very common, and we've taken on many over the years, but this is a level that we could not assume with our current budget. So just want to acknowledge that we have assumed a much more significant responsibility over the years without going and asking for any budget, really any budget accommodations that I can remember over the last 12 fiscal years.
So while I'm presenting the budget as we expect it to be in the budget today for the $12 million, given some of these uncertainties, it may be that we will be making a budget request back to the administration and to the legislature to accommodate some of these uncertainties. And so if that is the case, I will be back before the board and we'll present that additional supplemental budget, and that may change our budget, throughout this in the course of the fiscal year. But for what we do know now, with the additional, with the $12 million appropriation, on the next slide, you can see our proposal for the expenditures here. Again, really an annualized proposal. You can see here the large blue portion of the budget. The agency is largely, it's a people agency. That is the large proportion of our funding goes to the staff of the agency. You can see the next biggest proportion is the light blue portion of the pie, which is our consultants and contractors. These are again, our broad bench of experts that we contract with each year: economists, actuaries, clinical experts, pharmacy experts that we keep on contract and that we tap regularly in the course of all of our many different types of activities, of course, in our reviews, but also in terms of many different types of examinations. And so we reserve a large part of our budget for those contractors and consultants, given the uncertainty of those reviews. And then you can see, a small percentage goes to general admin for the agency. So on the next slide, this is just showing the difference between last year's budget and the proposal for fiscal year 2025, where the additional, the new funding would be dedicated. And consistent with what I just showed you, the new funding is generally dedicated to payroll and for staff. And so really whatever increase that we're getting from last year is moving into the payroll and the staff expense category, a little bit into the consultants and contractors, and the little bit into general admin, although that really is more of a reflection of we were lower last year and had some deferred costs that we're moving into the fiscal year 2025 category. But really, whatever new funding we're getting is really for the annualized costs of the staff. And then on the final slide, just to state again, in terms of the staffing levels of the agency, we've been very consistent in terms of the overall FTE count of the agency, around 60 to 65, really for the past 8 years of the organization. On the right-hand side, you can see this broken down by our departments. With the $12 million appropriation, we do think we'll be able to add 2 to 3 positions to be able to support the agency's work. But that's really going to be it. And we'll continue to maintain a very lean staff with that appropriation. Again, a lot of uncertainties about what happens in the future and may need to be back. But for what we know now, this is my recommendation to continue, I think, a very efficiently run and operated HPC. I welcome comments from the Administration and Finance Committee at this time.
Any comments? I'll just speak as one member of the committee that we really appreciated the opportunity to go deep with the HPC leadership on how the budget has been managed over the past year, some of the steps that have been taken to improve our efficiency, and we felt very confident about that discussion. Any other comments before we move to vote?
I think it's very unusual to look at an 8-year period of time and you look at all the productivity this organization has actually achieved, and to have basically a flat budget, that's incredible.
Thank you.
Here.
I would just add, and I think this came up in the committee discussion as well. I mean, we know there's the potential of 8 material change notices. We've got some ongoing work, some big projects. I'm thinking Dana-Farber BI. And so I'm a little worried about capacity. And you set the stage well, saying we may be back, but I think there's a lot of work ahead of us.
Absolutely.
David, Colleen may know the answer to this. Does the budget that's being spoken about in the legislature propose any additional funding sources, like from pharma and or PBMs or anyone else in there? And or if there were a need for a supplemental budget, could some of it come from additional folks who have not been paying? I understand it's getting ahead of things, but
Yeah, no, you're right on target. No, it's not in the state budget, but that's in the House and Senate bills to expand our budget to include additional funding sources from other market participants that we, regulate or oversee, but that are not currently included in our assessment is very narrow.
in which case, if we do need to come back,
It's contemplated, yeah.
it's contemplated through that.
Yeah,
Okay.
but we can't go up and do that. Yeah.
So just to summarize, the additional work that is part of our current responsibility that Commissioner Cohen was referencing, we acknowledge the stretch, but we're proposing a budget within, contemplating that. Any new responsibilities, we would need to stop, and if they're passed by the legislature, we need to stop, consider those. But if there was a need to ask for additional funding or propose additional funding, that would come back to the board. So what we're really voting on today is the budget that's been proposed for our current scope and responsibility of work, which we had, as Commissioner Cohen is referencing, we had some discussion at the committee level on review that it felt like quite a challenging set of work ahead, but management wanted to act as, responsibly as possible in looking at efficiencies and ways of accomplishing that work that didn't require a significant increase.
Chair, with those comments, I would move that we accept the budget as.
Thank you. And can we put the vote on the screen? And do we have a second for this motion? Thank you. So could I ask that all in favor say aye? Aye. And any opposed, nay? Okay, the ayes have it. So with that, that concludes the agenda for the public portion of our meeting. I thank all of you who are here in the conference room for joining us, and those who have come in through the website. Thank you very much. We're now going to take a vote to enter a confidential executive session, and we will not return to a public meeting. So this concludes the public portion of our meeting. Colleen, could I ask you to handle the vote for entering into
Absolutely.
executive session?
Madam Chair, we'll give you the summer off and meet again in September 19th with the meeting of the board. We do have to take a roll call vote because of open meeting law. So I will ask for a motion.
So moved.
And second. And starting with the undersecretary. Aye.
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 Thank you, Madam Chair.
Thank you all.
Thank you.